Thank you. Thank you, Stavros, for inviting me, and thank you everyone who's here for coming. So I've got two screens. Can you see my screen and do the slides move?
We can see your screen, yes.
Okay.
Yeah.
Okay, so this is joint work with Meltem Deysel and Marcia Trandafir, both of whom are in Copenhagen, although not Danish. And we're interested in how children who are diagnosed with a mental health condition, we focus on depression and anxiety, evolve over time from a young age to ages up to age 30, dependent on whether or not they were treated with pharmacotherapy. So I'm going to introduce that more slowly. Mental health disorders are common amongst children and adolescents. In the age group 5 to 14 in Denmark, which is where the study is set, 12%.
Sonia, sorry to interrupt you, but we're still seeing your title, the title slide.
Slides are not moving. This happens sometimes. Okay, I think I know what to do is disconnect the big screen and just work on the laptop. Stavros, are you there?
Yes, I'm here, yeah.
And does the screen move now? I'm scrolling it.
It's not moving, I'm afraid.
I'm going to stop share and restart share. This has happened to me once before, and it's something I haven't understood about having a big screen connected to my laptop.
Ah, yes.
And
yes.
Now it moves?
That's fine now, yes.
Okay, sorry for the disruption. So just going back. So mental health disorders are common amongst children and adolescents. In our setting, which is in Denmark, in the age group 5 to 14, 12% of children are diagnosed with a disorder. And more broadly, so that is the fraction of the population diagnosed. It's about 12% up to age 14 and 18% up to age 19. So if you look at children 5 to 19, that's a very high rate of something like, I'm not averaging exactly, something like 15% of all children. But now if you switch to those who are diagnosed at some time in their life, the research suggests that half of them were diagnosed by age 14 and 2/3 by age 24. So basically mental health disorders, when they emerge eventually, they do have a history. They tend to have emerged in childhood. So if left untreated, mental health disorders have inbuilt persistence, and this makes early intervention important. However, there are large treatment gaps, and it's estimated that in the OECD, these treatment gaps average at about 60%. So although there's a need for early intervention and a high prevalence of the problem, early intervention isn't as common. Children, similar to adults, are treated at quite a low rate. There could be lots of reasons for this, including children not coming forward to the health system, or a failure of teachers or parents to recognize symptoms early enough, or that there are shortages of supply and this just puts people off coming forward. But the focus of this paper is the question of whether the controversy over side effects of antidepressants might have contributed to this low treatment rate. So there's a class of antidepressants called SSRI, serotonin inhibitors. When these were introduced in 1987, they led to a sharp increase in antidepressant use because they were seen as much better than their predecessors in terms of having fewer side effects. However, in 2004, there was a sharp decrease in antidepressant use across the world following an FDA warning. The FDA is the Food and Drug Administration in the US, and they issued a black box warning highlighting suicidal ideation amongst teenagers as a potential side effect. The question remains controversial. We looked at a 2019 survey in a good psychology journal, and this reviewed all the evidence on that warning and argued that the jury was still out there. The tone of the article was that the warning was out of line because it caused a lot of fear and resulted in people who needed the drug and benefited from the drug coming off it. They also point to a US study that documented an increase of 14% in teenage suicides following this FDA warning. So that's all about the side effects. And it's interesting because of this controversy. But of course, the primary concern is not side effects, which affect a small proportion of people, but effectiveness, which is what we typically measure in clinical trials and applies to the broader population. The medical trials indicate about 40 to 70% effectiveness, but these are based on short-term follow-up of symptoms that are typically subjectively presented and subjectively assessed. However, this said, there are fewer trials for children than for adults. And I think I've said this already, they rely on the reporting of symptoms, which could also be affected by the trial. So what we do to contribute over here is we use linked individual register data in Denmark. This allows us to link school and health outcomes. We also have a lot of information on the prescribers. We take all children age 8 to 15 who've been referred to a child psychiatrist. This is, it is the case in Denmark that when the GP, who is the first point of contact, feels that the child might need pharmacotherapy, then they must escalate them to see a psychiatrist. In some countries, general practitioners can prescribe drugs, but in Denmark, they can't prescribe to children. They can to adults. So all children that seem to be at potential risk, i.e. potential need for antidepressants, are referred to child psychiatrists. We take that sample of children and we ask, does antidepressant treatment affect hard economic outcomes? Because the evidence from trials is all soft. It's symptom-based. So do children who have antidepressants compared with children who don't, conditional on diagnosis, have better school performance? We find they do, and particularly children whose mothers themselves don't have college. So these are typically children from poorer backgrounds. We then track these children beyond 16 to age 18 when they make choices about whether to continue in education. And we find that the users of antidepressants are more likely to continue, with girls being on the academic track and boys on the vocational track. We go further, same cohorts tracked over time across their life course to look at their employment and income, and we find very large improvements for those who were treated. So this tells us that there are, on average, good effects of being treated with these drugs. But there's a separate question of whether they might be over or underprescribed in general or to particular groups. And the overprescribing needs to engage with the issue of side effects. So what we do next is to use the marginal treatment effects framework, which allows you to study policy effects for counterfactual scenarios. So we can ask questions such as, if we extended this drug treatment to children who were not in fact treated, how would they have evolved? So we use the MTE framework to answer that question. And we also look at hospital data on children coming in with the ICD code that refers to attempted suicide or self-harm. And also just to be more general, because there might be other effects, for example, on your stomach, because if you're very stressed, you have stomach issues. So we look more broadly also at hospital visits, and we basically find a decline. So it seems that on average, children are doing better in their health and mental health, and in their functionality and future outcomes. Please feel free to chip in with questions as I'm speaking. So what is the contribution? This is the first attempt to document impacts of mental health treatment on children or in childhood using objective markers of all of these outcomes, not only education and economic outcomes, but also objective measures of mental health in the hospital data. Existing studies have tended to look, if we focus on treatment, not on mental health, but on pharmacological treatment of mental health, then these are the studies we've picked out as looking at this. And they are all looking at treating adult mental health on contemporary labor market outcomes. And largely they're finding no impact. So this tells us actually that it might be too late, that it might be that you can catch this. Of course, when you have antidepressants, I think trials tell us that many people, 4 or 6 out of 10 people, feel better. But the question is, do they feel better enough that this affects their test scores and their incomes? And we find yes. But it doesn't seem when you treat an adult that their labor market outcomes improve in any discernible manner. And so I think that's really interesting because it suggests that we need to intervene early for mental health, partly through the pathway of protecting human capital accumulation. Our second contribution is the one around prescribing rates, where I've already discussed, we look at MTE. This relates to a literature that's emerging, I think, in the last 10 years or so, in the US, Sweden. There's some papers looking at who you're assigned to when you randomly show up in A&E, and they find that there's a lot of discretion in the treatments you get when you show up, and that discretion matters. It affects health outcomes. So the sort of topic is that in lots of medical contexts, physicians have some latitude because it isn't always obvious how symptoms map into the treatment protocol. And that latitude causes variation in health outcomes. So this raises the question of whether there is such a thing as an optimal treatment or not. For mental health, it's very clear that there isn't. And so we're not going to be talking about which psychiatrist was the best prescriber, but rather if you create counterfactuals where you treat children who are not treated, whether they do better. Okay, I'm probably being repetitive here. I'll try to say this quickly because you can anticipate it. Denmark has a system similar to the NHS in Britain, where there's universal healthcare. With psychiatry, it's actually provided a lot through private clinics, which will be our focus. But you can also go to a hospital psychiatry department. And as you can imagine, more extreme cases will tend to go to the psychiatry department. But the more regular cases where you just need a conversation about whether to have drugs will more likely be in a waiting list and go to the private clinics. But all are fully reimbursed, so cost is not an issue here. So we condition our sample on children who've made contact with a child psychiatrist. This is what we abbreviate as CP. So I won't talk a lot about the hospitals. There were some issues like hospitals disappeared over this time because they were being merged. And also hospitals handle severe cases where there is less ambiguity in whether or not to prescribe, making that sample less interesting for our question, which is, what is the right margin? Where should you stop prescribing? So national guidelines recommend therapy as the first line of treatment, and we will be discussing therapy. And when when antidepressants are considered helpful, then SSRI are the preferred or recommended genre of antidepressants. And I won't read through this, but essentially the costs are roughly similar to those in the UK, and they're not large enough that they could explain the differences by SES that we're going to discover. So what's our empirical strategy? The relationship we'd like to estimate is one where you use antidepressants, AD, that's binary, yes or no, and the outcome is, let's say, school test scores. It'll be our primary outcome, though we look at others. So we're interested in how the school test score at age 16, which is why it's just YI, no T, depends on whether you use antidepressants or not in the run up to age 16, from age 8 to 15. What might jump to your minds immediately is, doesn't when I started matter, doesn't how long I was on antidepressants matter. So we do look at this separately. We're a bit underpowered to look at results by age, but it seems that if you start younger, you do even better, but it's imprecise. And we don't look at duration. We do it in a robustness check, sort of to satisfy referees, because duration is endogenous. So the prescribing, and maybe this is clearer if I introduce my instrument on the next page, but basically we're going to, or let me come back to this. Okay, so this is a regression of test scores at age 16 on whether at some point in the period you were age 8 to 15, you had antidepressants, and the bold X is the characteristics of the child, all baseline characteristics available in rich admin data. And then importantly, there are fixed effects for birth year, diagnosis year, and municipality of residence. But the concern with just going ahead and estimating this equation with OLS is that people may select into antidepressant use, and those who select into it may have unobservables correlated with test scores. So the stereotype is that there's a highly educated, pushy mother, and she's going to find a psychiatrist who will treat her child. It's an interesting stereotype because I don't believe that parents want antidepressants. Parents just want the best treatment, and that may not be antidepressants. So a parent may well sort into a higher quality psychiatrist if they know which the quality ranking is, but they won't select into psychiatrists who are more likely to prescribe. Well, I wouldn't, but still we try to deal with this. So we use an instrument which is similar to, if you're economists, similar to what economists call the judge instrument or the judge leniency instrument. If you haven't come across it, it's fine. The idea is essentially that psychiatrists will vary in their taste for prescribing. So they may have the same education and in many ways be similar, but when they meet their patients, some are just a bit more drug friendly and others may be more therapy friendly or have other ideas. So for every child age 8 to 15 who has their first contact with a psychiatrist, the instrument for whether they are on antidepressants is the prescribing propensity, PP, of the psychiatrist they saw for other children that psychiatrist saw in the same year. And so this is essentially notionally the idiosyncratic prescribing tendency of the physician you see. When we use two-stage least squares with this instrument as an instrument, we're going to get the local average treatment effect we estimate is going to be the weighted average of the causal effect of antidepressants among those who would not have received the antidepressant had they seen a different psychiatrist. So in this case, we're picking up compliers to the instrument. And the common sense way of saying this is that we're going to be talking about children who were on the margin of being prescribed in the particular sense that the psychiatrist in Denmark might disagree on whether or not to prescribe. So some children are clearly doing well. They're buffered by, say, their family, and they're showing all signs of functionality. Then the psychiatrists may all agree not to prescribe. And there may be another child who's, say, hallucinating, and all psychiatrists would agree that by the guidelines you prescribe. So those extreme cases are not going to enter our estimation. It's going to pick up the impacts of antidepressant treatment for cases which were ambiguous in sort of medical eyes. And this is interesting. This is actually just what the instrument gives us, not our choice. But it turns out in this setting to be quite useful for answering the question about whether Danish psychiatrists are over or under prescribing. So this is just quickly, this follows a judge leniency tradition, and a few studies also use physician leniency. However, a caveat to our NICE strategy is that assignment to a psychiatrist in Denmark is not institutionally randomized. You are allowed to sort. You are allowed to travel further and go to the next person. However, once you condition on municipality and year of diagnosis, our anecdotal evidence is that wait times determine assignment. However, we don't rest on that. We provide, and this is standard, like all other studies, we provide tests of instrument balance using a very wide and rich set of characteristics pertaining to the mother, the father, and the child in the registers. And moving quite slowly, I just saw the time. So one concern with our focus on antidepressants is, where's therapy? Is it negatively correlated? Is it positively correlated? Are you omitting it? Is it biasing your estimates? So we consider therapy twice. First, we consider whether the child had therapy before they saw the psychiatrist, which is the time at which they could get a drug. So we have the data on that, and we see that therapy taken before the first contact is uncorrelated with our instrument. So in plain English, that means that children who had therapy before they saw a psychiatrist were neither more nor less likely to see a high prescribing type. However, psychiatrists who are high prescribers for antidepressants are actually high prescribers for therapy after you see the psychiatrist, and also higher prescribers of other N-class drugs, which include stimulants and psychotics. So what could be happening is that what we're picking up, which is the effect of seeing a high prescriber, is actually the result not of antidepressants, but because of therapy or psychotics used after seeing the psychiatrist. So this is a first order issue, and we use the same instrument defined on these other medications and control for them. So for the data, we actually started with the full population, but the immigrant children were clearly sorting into psychiatrists. And for the instrument to be valid, that's not allowed. So we restrict to native children who were born in these cohorts such that we can track them till they're age 16 and actually beyond. Here's some interesting stats. They seem high to me, but I'm an older generation. Of all native 8 to 15-year-olds, 6.8% arrive at the door of a child psychiatrist. Of all these children that are referred, 15% fill an antidepressant prescription, and this median age at which they start on antidepressants is 12. Low SES children, just in the raw data, are more likely to have mental health disorders and less likely to be on antidepressants. So these children are in more need and have less treatment, even in Denmark, where there's no financial incentive for providers to distinguish high and low SES. Also, our raw data show us that mental health disorders are associated with weaker school performance in all subjects, but more in maths than in language, which is Danish. So I'm now going to move on. I have a very quiet audience also, I guess a small audience. But if you would like to ask me things, or if you'd like me to remove, I don't know if you're economists, completely remove technical jargon, I believe I can. So just chime in and tell me, because I think if I see right, it's a small audience, so you can talk to me to get more out of it, and you can tell me to drop the jargon. So would anyone like to say, should I carry on as I am? Is it clear?
I think it's okay to carry on as you are, Sonia.
Okay, thank you. So this picture, it has the propensity of the psychiatrist to prescribe SSRI drugs on the x-axis, the horizontal, and it's a histogram. So it tells you that the range of prescribing rates is between 0 and 30%. And it tells you that's the histogram, and like the median is, we know the median is about 15%. And what's interesting as a validation of the instrument is that the actual uptake of antidepressants is increasing monotonically in the prescribing rate of the person that the child sees, and that's the solid black line. Also, these prescribing rates have a meaningfully large impact. That's another way of saying the first stage is strong. Then interquartile shift from the 25th to the 75th percentile in the distribution of the propensity to prescribe increases prescribing rates by 7%, which is half of the median rate. The biggest, most important challenge here is, are we just picking up selection? And the answer is no, because we showed that the instrument is correlated with a very rich, uncorrelated with a very rich set of observables. So on the left-hand side is the correlation of using antidepressants with lots of characteristics of the parent and the child. And on the right is the correlation of the instrument. And you see a few cases like parents are married on the left, showing that when the parents are married, children are more likely to use antidepressants in the raw data. But if you look to the right-hand panel, the correlation with parents are married has been driven to 0. So basically, this tells us that our instrument, there's one little deviation for the second income decile, but with multiple hypothesis testing, this is ignorable. We do more with this. We also show that there's no correlation in a non-parametric manner. Then we have this problem, which is called the exclusion restriction. We are implicitly going to say that if you saw a high prescribing type of psychiatrist, you're more likely to get antidepressants and you're more likely to be well and rich. But what if it's not about them prescribing antidepressants, but maybe it's to do with their characteristics? For example, I saw a woman and she was really nice and her bedside manner was kind, and I just felt so much better because my home life is quite rough and I just benefited from seeing that nice woman. So we take that out by getting the register of characteristics of the psychiatrist in Denmark and controlling for all available traits. So we have the gender and age and race and experience of the psychiatrist. So we control for all of that. But even after that, you might have 2 female psychiatrists, one of whom prescribes antidepressants and another of whom is actually prescribing therapy, and it's correlated and our instrument is picking up both. So we control for all other treatments and the results are robust. The third concern is maybe a slightly more technical one, which I can move over quickly, which I also already demonstrated in that histogram. We need, when the instrument is continuous, we need it to be uniform or monotonic, which basically means that if a child was prescribed by a low prescribing specialist, they must be prescribed by a high prescribing type. You never see that because you don't see kids moving between, well, you see actually 14% move, but for us, because those moves could be endogenous, they're I think I said this, we're looking at the first psychiatrist you see. So we just follow a literature. It's not just us in checking that the first stage is positive, whether you're a boy or a girl, whether you're rich or poor, and then redefining the instrument so that it's defined on an outside sample and applied to the inside sample. And all these checks look good. I'm thinking that but because of time and the interest of the audience, maybe I shouldn't click on these results, but please tell me if you're intrigued and I should. So these are the main results. They're reported in standardized format. In other words, children, the top estimate of 0.52, it's saying that a child who's on antidepressants through this random assignment, conditionally random assignment to a high prescribing type, comes out at age 16 with a test score in maths that's 0.52 standard deviations higher than a child who similarly got diagnosed, saw a psychiatrist, but didn't have that treatment. And you have a fairly big coefficient for Danish, but it's not statistically significant. We report Anderson-Rubin confidence intervals to allow for the fact that the first stage F is 82 and not larger, like 100. And the reduced forms are following a similar pattern. We then look, because so basically we see that these, on average, children do well at school after having antidepressants. So it seems plausible that they're also feeling well. But we do look at whether maybe these rare events of suicide attempts or self-harm stick out for the few children that maybe were not doing so well. And we find no evidence of this. Now, we can't ever be completely conclusive because there could still be one child that was self-harming, but the vast majority of 52,000 children in column 1 were less likely than the control group. So it's really important. It's not less likely than themselves. It's less likely than the control group to have committed attempts at self-harm or suicide. So we see though, and if you read along, you basically see the improvements in suicidal or self-harm behaviors come from girls, and read down to the hospital visits. These reductions also come from girls, but these reductions come from girls and also from high SES children. Whereas the suicide and self-harm come from girls and low SES, that's row 1. And if you go to the bottom row, improvements in hospital visits come from girls and high SES. Now we start tracking these children to see if those test score outcomes map into anything real, because after all, your school scores are just scores. They're not like money in the bank that allows you to buy a house. So we first look at continuing after age 16, and you see these results for girls in column 2 at the top. Girls are quite a lot. That's 50% of the mean. There's a big effect on girls staying in the academic track beyond compulsory. And if you look at column 3, vocational track, you see an even bigger effect in relative terms, 0.316, for boys continuing on the vocational track. And the third row is including academic and vocational in one lump. We then move on to look at income and employment when these same children are aged between about 25 and 30. And we see, if you just look at column 1, total income goes up, labor income goes up, and being employed or in education goes up. When we break this down, you see effects basically across the board, but they're more precisely determined for boys. That sort of makes sense. Boys are more likely to map their test score gains into earnings, more likely to work. But if you focus on the last row, you see education. The low SES children, it's not significantly different, so I wouldn't emphasize it too much. It's not to say it's bigger. So I'm looking now at the third row at 0.27 versus 0.258. So low and high SES children are more likely to be employed or in education at age 30-ish, but it's not more because these differences are not statistically significant, but it's not less. That's notable. So we also, the next check, what I'm showing you now, is motivated by the fact that, as I discussed when I was explaining my instrument to you, that instrument is going to pick up compliers. It's going to pick up a fraction of patients over whom psychiatrists might plausibly have had differences of opinion. Now, those compliers might be very special people. They might all come from a particular demographic group, for example. So we follow a recent paper in identifying the average characteristics of these compliers and also their share. So what you see on this page is the share, and 31% of the population are compliers. So that's quite a lot, actually. I'd say more than I would have expected. And then you look at their characteristics. What you can focus on is the third and sixth column. Let's look at the third for now, called ratio. Let me just take one case, like high SES on the left, and column 3, the number is 1.031. This tells you that the characteristics of, basically that compliers are similarly drawn from the high SES distribution as the rest of the population. So if you break it down, high SES, the whole population, 74.7% of all people are high SES. Go to column 2, 77% of compliers are high SES. The point is that 74.7 is very similar to 77. And now we did a number of robustness checks. We allowed that being on antidepressants rather than not could affect whether or not you take the test. So this would be a classic case of selection into the outcome. So we first model the probability of taking the test, and then we put bounds on it. We look at whether maybe you were having antidepressants at the time of the test, and this caused some contemporary hormonal changes that affected your concentration. But we don't include children. We exclude children who were taking AD at the time of the test. We then include school fixed effects, although we didn't initially because there are very few children per school, but the results are robust to this as well. And then we examine whether people move across psychiatrists. 14% do, but they don't move towards higher prescribing in any significant way. So I'm happy to show you any of this, but I think we're running low on time. So let me move to, this is more robustness checks. What you should eyeball is that the coefficient, which is the dot, each dot is from a different regression, from a different robustness check, which if I had lots of time, I should motivate for each case. And you see the coefficient is fairly stable, and except for one case, is significant through all these checks. We then break down this, the results by gender and by SES, and we see very similar effects for boys and girls, but much larger effects for low SES children than for high SES. Low SES is defined here as mother has college education. This is what I say here. So you could think intuitively of the mother who has a depressed child being more able to protect the child's test scores or school performance from their depression than the less educated mother. But in the raw data, we can see, this is not the raw data, this is the instrument. In the raw data, which is not here, it's on another slide, you can see that low SES children are being prescribed less, even though they need it more. So because the policymaker would be interested in whether this gap in prescribing is coming from the psychiatrists or from the parents. We plotted the prescribing gap for their averaging over all their patients for each psychiatrist. So what this tells you, that peak at the peak in the blue histogram tells you that more than 30% of psychiatrists sitting at 0 have no gap. They prescribe on average at the same rate to high and low SES kids. But then you see more mass to the right of the 0, and that tells you that amongst the rest of the psychiatrists, a larger fraction prescribe more to high SES children than to low. That what this tells you is that it's sort of quite distributed, and we're not quite sure. It's probably some combination of the psychiatrist and the patient and their interaction that leads to low SES kids being prescribed less despite the need. Now, this is a description of marginal treatment effects. If you want to know, please speak up, but I'm going to assume you don't want to know. So the intuition for this is that we have a local average treatment effect in our instrumental variables estimate that you've already seen. And this is averaged. But we now want to break it down across the distribution of essentially the residual from the first stage. So we want to break it down by the distribution of types of people conditional on their traits, like I'm a woman, I'm a girl, not a boy, and I saw a high prescriber, not a low prescriber. We control for all of that. And then there's some idiosyncratic variation V left in whether or not I use antidepressants. So it's a kind of unobserved proclivity to use the treatment. And in economics, that language is used even when the treatment's a policy. So it could be the treatment is childcare, and the government in Germany just expanded childcare facilities. So you'd still have a concept of this V, which is the proclivity to take up childcare, conditional on who you are and your contact with the system, in this case, which psychiatrist you saw. So when we essentially break the treatment effect down, we get the marginal treatment effect. We get the treatment effect across the distribution. What we see here is that it's positive for maths, basically across the whole distribution. The black line on the right-hand side lies above the 0 flat line through the distribution. So this suggests that if test scores were picking up how a child feels sufficiently well, then antidepressants would not do any harm if you extended them to all children who are diagnosed, not all children in general. With Danish, this is less clear. So there's a positive average treatment effect, but it does go into the negative region. We then drew the MTE by SES, but I think I won't go into this. Let me just tell you, we did 2 policy experiments and then wrap up. So we used the one reason the MTE is done is that it allows you to do simulations or run counterfactual policy experiments on the data. The policy relevant treatment effect conditional on X, which I think of as who you are, the characteristics of the patient, is the mean effect of moving from a baseline policy regime to some alternative policy regime per person who is shifted into treatment by that policy. So we run 2 policies. First, maybe it's a slightly loose language, but we call the first policy making psychiatrists identity blind, by which we essentially mean that we force in the data, we force the prescribing rate for low SES children to be the same as the prescribing rate for high SES children. And then we look at how those low SES children that are moved into treatment by this counterfactual perform later in life. And then we do another, because there's a discussion in health economics more broadly about how much discretion doctors should have. So this is quite crude, but we say, what if we chopped off, well, not really chop off, but move up? What if we essentially moved the bottom 25th percentile of prescribers up to the 25th percentile? And we do the reverse at the top, bring the 75th down. Would people be better or worse off? And we estimate these policy relevant marginal treatment effects, which are the red lines, which pick up the same concept, the treatment effect, but for those people who only through our policy simulation are pushed into treatment. And the upshot is that with both the simulations I showed you, or I discussed, sorry, still go there. But both the simulations I discussed, these red lines are positive and the switching is good. So compressing the distribution from the bottom is good. So that's in the direction of high prescribing. And moving some of the low SES children that were not treated into treatment is good in the sense that it benefits them. So to conclude, we find that antidepressant treatment in childhood increases test scores at age 16. More precisely for maths and girls, although effect sizes are similar for the other groups, and significantly more for children with less educated mums. We find that treatment effects are larger for these low SES kids, but in fact, there's negative selection into treatment on SES. However, there's positive selection conditional on observables. This just means in English that those patients who had an unobserved sort of proclivity towards treatment are more likely to get treatment. So that's what we would like to see. The results I just discussed with the MTE framework suggest under treatment, and we couldn't see any side effects. So of course, there still could be one child in our sample that did have a side effect. So one always has to be careful writing that off. So I will leave these on the, also the treatment effects we identified, they close the raw depression gap in test scores. And also I wanted to leave on the table the result that failing to treat mental health disorders in childhood can be an important, quite big source of inequality in academic achievement and later on in income. Okay, I think I'm done.
Thank you so much, Sonia. Thank you very much indeed. That's a tremendous presentation. Thank you. I wondered if you wanted to just, well, feel free to keep the sort of the presentation on the screen if you prefer. Wondered, we're a very small group, and I can only apologise for the low attendance. I wondered if people wanted to just switch off. Oh, we've lost Francesco. So we just left that with me. I'm so sorry about this. I'm not quite sure why we have had such a poor turnout for this webinar, because it was advertised. So I can only apologize for that.
What's normal? Because actually these days with the term on, and at least in Warwick, there's lots of seminars. I can imagine that if we don't have this social interaction of being in person, people may not log into online seminars. But do you usually get a good turnout?
I have to say that, I mean, maybe Sophia can say more here, but basically